Hi everyone. We're going to be talking about spinal muscular atrophy. We are group 7. And the people who worked among this presentation are myself, Valerie, Geetika, Arjun, Aydin, Hershdeep, and Siddharth. So for content review, we're going to be going over the background, the research question, gaps in research, method, results and discussions, and the conclusion.
This is the background information for spinal muscle atrophy. Spinal muscle atrophy is a neurological disease that decreases the sensitivity of motor neurons to signals from the brain. This leads to a decrease in motor neuron count and weakens the muscle. It is caused by a recessive mutation of the SMN1 gene. Because of the complex nature of this disease, there are only a few medical facilities throughout the country that can provide adequate care. SMA type 1 is the most aggressive form of spinal muscle atrophy. It is the leading cause of mortality in infants, and the most common symptoms of this disease are a difficulty with swallowing and sucking, and a higher risk for respiratory infections, which is the major cause of infant mortality. The mortality rate is 95% by the age of 18 months, and the median survival is 7 months. A less severe form of spinal muscle atrophy, type 3, has less severe symptoms if they do appear, and the symptoms are mild muscle weakness, difficulty walking, frequent respiratory infections, and it also affects the ability to walk or stand. Of all the infants that develop spinal muscle atrophy, 58% will develop type 1, whereas 13% will develop type 3.
The next section in the background section that we'll be covering are chronic care challenges and inequities of SMA. The first challenge is the high treatment costs. Because of the special care and complex treatment, that's what drives up the costs for the care. SMA type 1 patients can see an average of $137,627 per year. And for other SMA types, the average is about $76,371 per year. The next challenge is that underserved communities face financial burdens that limit their access to care, making it hard to get treatment. Travel is another factor in challenges that many patients face, as because care is limited, many treatment facilities are far away, which one can contribute to costs, but also takes away a lot of time in terms of time spent traveling as well as time spent actually receiving the care. Lastly, advocacy can help improve access and treatment for those in need.
Now let's look at some of the gaps in research in regards to SMA. So the first gap in research is the financial burden. There's often limited knowledge on the financial problems faced by families affected by SMA, especially those in impoverished communities. So like we mentioned earlier, patients with SMA often require frequent and niche medical care that only a few hospitals across the country can provide. This scarcity of care drives up the cost of treatment and service that not everyone can afford. Like we mentioned, SMA type 1 alone, patients have to pay on average about $137,627 per patient per year. And for comparison, the median household income in the US in 2022 was $74,580. Now, this issue is exacerbated in impoverished and in underserved areas that have minimal access to healthcare facilities, emergency services, expert medical professionals, and more. There's also little empirical data available to pinpoint the exact issues plaguing these communities because there's such few case studies and reports obtained. Therefore, we don't know how much that they can afford, whether they can even pay for general checkups, and if they have a support system at home. By studying underserved communities, we can learn about how to better address their healthcare needs when dealing with SMA, and this can be done through introducing policy initiatives that offer financial assistance. The second gap in research is diagnostic procedures. Genetic blood testing and observing phenotypes and visible symptoms are two of the main diagnostic techniques used to detect SMA. However, these methods can't always be reliable. For example, some people with SMA don't exhibit the typical symptoms such as mild muscle weakness and difficulty walking until adulthood. Undetected, this could be really detrimental to the growth of newborns. Genetic testing can also be invasive and difficult to perform in newborns and pose a barrier to diagnosis. Novel testing methods for SMA have to be researched, developed, and tested as a result of this. And this is really important for people in underserved communities who may not have access to medical facilities in order to get tests or a physician to examine them. Finally, quality of life after diagnosis. Minimal information about patients' prognosis or one's course of disease is available. And although we know that there's difficulties in accessing healthcare due to geographic location and finances, there's not enough empirical data present because less case studies are performed. There's also minimal economic data, which makes it even more difficult to narrow the disparities and allocate resources accordingly.
So our research question is, with the inequities of healthcare, how does SMA type 1 and 3 affect people in underserved areas within the US? So our objective was to help it understand the impact of SMA newborn screenings and the quality of life of those that were diagnosed with SMA. So we looked at exposure being SMA type 1 and 3, focusing on the populations of SMA individuals and parents who had an SMA child, and looking at the outcomes of how the quality of life and care that was received by SMA. With these three criteria, we were able to use Web of Science, where we analyzed 4 specific keywords, which were spinal muscular atrophy, also known as SMA, diagnosis and screening, life impact, and patient. With this, through the Web of Science, we reviewed 253 preliminary search results that were able to organize into which was considered eligible and non-eligible studies through the bibliometric R program. With this, we found 100 eligible studies and 153 that were non-eligible. For the 100 that were eligible, there were 88 that were specific under articles and 12 that were under review. With all of this in terms of the eligible studies, we're able to look at the results of being put into graphs. So the first one that we're looking at is the journals with multiple top 100 cited articles. This is able to portray where the top 100 cited articles containing SMA were published under these specific type of journals. By looking at this, we were able to see that New England Journal of Medicine had the highest amount of most cited articles, with the frequency of between 1,200 to 1,400. The next graph that we'll be looking at is the utilization of SMA in clinical diagnostic research. With this, through the Web of Science, we were able to see the top 100 most cited articles with the most mentioned keywords. So between the 100 articles, we were able to see that the most keyword that was used within was phenotype, portraying towards SMA with about 1340 search articles.
For our methods and results, we analyzed a case study from the article Understanding the Experience and Needs of Individuals with Spinal Muscular Atrophy and Their Parents. In the study, 5 individual group sessions and interviews were performed. 11 individual group session interviews were performed at 5 clinical locations across the US in English. The inclusion criteria were SMA individuals and parents of SMA child. To the right, demographics table of individuals and parents of child diagnosed with SMA. As we see, the gender in this case study was mostly female, accounting for 77% of all participants, with male participants only making up about 23% of the study. For the age range of children with SMA, it was predominantly 30 children were in the, or I guess children, yeah, in the range of 3 to 11 years, with the smallest group being less than 1 year, with only 5. And for diagnosis of SMA type 1 consisted of 12, type 2 consisted of 29, and type 3 consisted of 22, making up 90%, 45%, and 34% of all participants in the case study in the respectively. Now looking at the results, the table demonstrates the positive and negative views of the newborn dried blood spot screening program from parents of those affected by SMA. For context, NBS is a public health service that provides genetic testing for infants that may potentially identify genetic diseases at an early stage. Then this makes it more difficult for the disease to progress, and generally, it provides a more optimistic prognosis. The chart is derived from focus group sessions and interviews conducted from a study pool of 96 participants. For the positive implications of the NBS program, parents found predominantly that early access to care was essential to get in contact with specialists for the treatment they needed for their children. However, the study found the diagnosis had a substantial negative impact on the relationship between SMA patients and their parents. Although resources are available for early screenings of infants for genetic disorders, the program also affects the livelihood of patients and their families. NBS may lower health disparities in society, but diagnosis may cause more of a burden if it has very little to no impact on the patient's life. It could hypothetically affect them regarding finance and mental health. If we look at the table below, we can see in the diagnostic journey three challenges. The first was lack of knowledge, challenge in differential diagnosis, and communication, especially the sensitivity of the issue of SMA. For newborn screening, we found that earlier access to care, a shortened diagnostic journey, and families able to prepare were three positive impacts of the NBS program. If we look at the psychosocial impact, we see that loss of sleep or stress, family finances, and uncertain in treatment slash expectation, we see that a diagnosis of SMA can affect families and those affected with SMA pass beyond the diagnosis. To the table to the right, you can see the positive and negative views of NBS. Mostly, parents found for the view that's most positive to be earlier access to care and a shorter time to diagnose, with the most negative view being how SMA prematurely affects the relationship between the parent and the child.
So for our discussion, the most cited articles about SMA in children that we found established a baseline for newborn screenings, with their genotype being SMN1, and our research focused on keywords relevant to senior authors that had multiple papers. The main reviewed article that we used was titled Understanding the Experiences and Needs of Individuals with SMA and Their Parent, and we found that this is the most beneficial approach to use when dealing with families and children that are affected by SMA.
In conclusion, families affected by SMA experience high burdens of living due to extreme diagnosis. To help relieve this issue, newborn screenings are able to minimize the diagnosis of SMA within a child.
So here are our references that we use to help us do this research. We would like to thank everyone for listening to our presentation.